All right, so we are on week 9. Week 9 has a bunch of different things. We've just done our quiz. We do have a discussion question, and we do have another sim chart. It's on the abdomens. And then also there is a dosage calculation. Now, a question students always ask, do I have to use that form or can I write it on a piece of paper? I don't care. And I know Professor Pace Chismar don't care either, as long as it's turned in. If it's easier to put it on the form, use it. If you want to sit there and just write out in a pencil, take pictures and send it, it doesn't matter as long as that assignment is complete, okay? Because I know many students will say, what do I do? So we're going to be doing musculoskeletal and neuromuscular. So we're going to start out with musculoskeletal. Can you see the slide? Can you see the PowerPoint?
Yes.
Okay, thank you. I know last week we had an issue. I had just gotten my computer. I'm getting better at it. So first of all, let's look at the pictures on the first slide. It tells a lot of stories and a lot of concepts you need to know on this chapter. The top left is a little baby that the hip isn't in the socket, called developmental hip dysplasia. You find it at birth, and that's a Pavlik harness, okay? The picture to the top right, we're going to be talking about casts and cast care and teaching that we need to do. The bottom left is a spica cast, which also works with hip dysplasia, one of the other treatments we can do. And then the bottom right is about traction. And we're going to talk about what traction is, what it's used for, and nursing functions, and what do we need to chart, and how do we take care of that. So let's first talk about a child who can't move, that's in bed, on bed rest. And it could be that way for many reasons. Could be that they're sick, injuries, infections, septic, all of that. But it could also be congenital or degenerative disorders. And we know all of those things can cause a child all of the symptoms of an adult. You can have foot drop, you can have decubitus, you can have atelectasis, and you can have DVTs. Everything an adult can have, so can a child, and we do need to monitor them easier. The one thing about kids, they don't weigh as much as adults, so they're easier to flip and turn and rub and whatnot, most of the time, not all the time. So we know there's going to be that decreased muscle loss. We have to be aware. We've got to be aware of nutrition because they need to get proper nutrition for that bone and for the calcium, etc. And of course, patient on bed rest, immobilized because of whatever reason. We got to worry about their lungs, their heart, the venous stasis, etc. So again, things that we need to be aware of. What about their psychological? Remember, you got a kid who's older, let's say, or just even a younger child that's very cognitively aware. They're, quote, normal children, and they're placed on this prolonged bed rest for whatever reason. These kids are going to get angry. You've got to keep them entertained somehow because they're going to be frustrated, helpless, and it's not just this child that's going to have a problem. It's the whole family, the mother, the father, the children, the grandmother, everybody is going to be involved with it. Many hospitals, I know the one I worked at in Miami, they had each floor or each area had parent groups that met monthly, and they would sit there and talk about how they felt. And it really did help. Some of them had found certain things that other patients, children's needed, and they were helping each other. So actually, a person involved in care, that's trying to find things is the person to teach the other parents because they've already been through it. And it works really good. So let's start talking about musculoskeletal and all those things that can happen. Well, kids are always falling down. It's just part of playing and being who they are. We know it happens during play, and we know, of course, sports will cause them. Now, contusions, ecchymotic area, no big deal, right? It can be. Remember, not all of that ecchymotic area. Sometimes you see a small area on the top of an arm, a leg, or whatever, but it's swollen more down in the tissue. Our biggest concern is going to be neurovascular and blood supply. So again, always going to be an answer to a question. What do you always check in an orthopedic or these type of injuries? Your blood supply, your neurovascular signs. Now, dislocations do happen in children. I think the big one that I've seen the most is what we call a nursemaid elbow. This is usually your toddlers. And you take their arms and you swing them around and they have fun, right? And then their elbow pops and it goes straight and it stays straight and you can't bend it. And if you try to, it does hurt. So basically, your ligament stretched and it just clicked out of joint, is what happened. It dislocated. And all we do is just hold it and click it. It doesn't hurt. You don't need sedation. And once it's in place, it feels better. And we just put a little sling on them for a couple days and no more swinging by the arms because we know those tendons are loose. Look at these poor Downs children. How much more can happen to them, right? We've got leukemia, hypothyroidism, cardiac disease, and now we've got problems with hypertonia, which they could take their feet, put them behind at the same time their head, and they could pop their joints out. Our concern with dislocation will always be blood supply, checking neurovascular signs again. Brains, probably one of the most common sports injuries. You know, I used to play sports in high school and I played sports in college. I had six brothers. They were all sports people, so I was part of that too. And I would sprain myself like crazy and it hurts. So the problem with a sprain is, all of a sudden it swells up. It's the pain, it's the blood being gone, and it hurts. It's painful and it causes you not to be able to really walk for a while. So we're going to go into what do we do there in a second. Strains are when we tend to do things over and over and over again. Things like shin splints and stuff. And again, they get swollen and they get painful and they hurt. So, what are we going to do? It is the acronym RICE. Rest, ice, contain, and elevate. I know when I played sports, for instance, volleyball, I'd go up, spike a ball, come down, and I'd rip my ankle, land on my ankle, and I could hear it go. I mean, you could feel it tearing. So immediately I'd sit down on the floor, put my leg up in the air because I did it more than once or twice. I mean, that's something I did all the time. So it swells so quickly. So if you rest it, ice it, which contains it, which compresses, and you compress it, you're decreasing the amount of swelling that's going on there. And of course, putting it up in the air. We also now, and we didn't many years ago, will put casts or splints or some sort of support on that ankle or wrist or whatever as it heals. And they feel that does help. Years ago, we didn't at all. They used to put an ace bandage on, give you crutches, and that was it. Today, they feel that that splint helps it feel better. Now, fractures are really common in children. It's one thing, they fall down. What do? You put your hands out, right? Fractured wrists are the most common of all of them, all right? Now, if you get a newborn that has a fracture, you need to really be aware that that's not normal. Those bones on newborns and infants are very soft and malleable. It takes a heck of a bang or injury to create a fracture. So if you see anything like that, you should report it to the doctor, and it should be investigated. Because the job in child abuse as a nurse is to protect the infant. Now, I'm going to tell you a story, and it's not a nice one. It was this little 3-month-old baby boy who the mother brought the child in her arms, complaining of some pain or some discoloration behind the ear, a little bit of swelling. And I brought that child back into the triage. I was doing triage. And I picked the child up gently, the butt and underneath the head and neck, and picked that child up easy to put it on the scale to get a weight. Because you always do a weight. It's the first thing I always did. When I put my hand underneath the neck and went to lift, my fingers sunk into the skull. And I went, oh boy, here we go. So I did all my assessment. Now I'm trying to maintain being professional. I think I know what's going on there, but I just need to get the assessment, get the information, and keep the mother calm, the baby calm, and make sure that I get this infant safe. My job is to keep it safe. So I told the doctor, told the charge nurse, they called DCF, they called the police. The doctor told me when I told him of my suspicion, can you please right now take that child over to x-ray and get an x-ray of the skull? And if you see anything, do what we call a bodygram. You know, a chest x-ray film on an adult can fit a whole infant. We do bodygrams, as we call them. And you could see the arms, the ribs, you can see hips, you can see the legs, the whole body. Well, when I saw the fractured, and it was a depressed fracture behind that left ear, I said, all right, let's do the x-ray. On the x-ray, fractured right humerus, fractured ribs, and a fractured femur. Okay, it gets worse. This child had a twin. So the police, DCF, said, we want to see the other baby. They brought the other baby in. Very similar injuries on that child. Oh, it gets worse. They had a 2-year-old son who they also brought them in and found out this child was walking around on a fractured femur and had multiple stages of fractures, healing, whatever. Now, can you imagine me as a nurse dealing with this and seeing this and angry because a child's been hurt? You've got to maintain professionalism. You have to not judge because you don't know who did this to that baby. It could have been the mother, but in this case, it wasn't. It was the father for whatever reasons. But today, I know that these children are safe because of what I did and how I acted. And I don't like doing things like that, but when it comes to children's safety, sometimes you gotta. So, types of fractures. When the normal fracture fall down and there's no skin broke and there's swelling, let's say on the wrist, swelling and painful, you can't move well, that's a simple or a closed fracture. There's no skin breakdown, so the skin is intact. There are times when the bone comes poking through the skin. That is called an open or compound fracture. Now, priority. Priority on an open fracture. Now, yes, it hurts, but your priority is to prevent infection or osteomyelitis. So antibiotics immediately. Yes, I have my pain medicine in my other hand, like I always do, but the IV antibiotics are the most important. And again, how do you monitor if there's any sort of infection? You're going to check their temperature, which we do anyway. There are complicated bone fragments. There's bone fragments that could damage other organs. Think about a fractured rib. It could puncture a lung. That's what that means. And then comminuted is when bones shatter in little pieces all over the place, and they hurt because there's pieces of sharp bone in the muscles and the nerves, etc. Or something, we say it's a fracture, but it's called an avulsion. The bone is attached to tendons and ligaments, which helps them move and keeps them mobile, right? Well, the bone comes away, so there's swelling, there's pain, but there's decreased motion. That is an avulsion. That's a different type of fracture. Now, children, fractures, the difference. Children's are still growing, right? They have something in their bones called an epiphyseal plate or a growth plate. It's at the end of the bones. So it would be at the end of the elbow. It would be, be up the knee or below the knee. I mean, all of these bones, we have to, if they are broken, we've got to make sure that they're set perfectly in alignment, or you're going to have a short or crooked finger, arm, leg, whatever. So these type of fractures will go to the OR. They will do an open reduction, internal fixation, plates, screws, whatever, to keep it in alignment so that these bones grow at the same length as the other side do. So that's what that is to prevent. So epiphyseal plate is where you grow. Now, children, look at the neonate. They heal their bones in 2 to 3 weeks. Well, this is going to make a difference when we talk about club feet, when we talk about hip dysplasia. Neonatal period is the first 28 days of life. So you've got, I mean, they're born. By the time they're a month old, they could have healed something. So early intervention is what we need there. And we'll go into those things. Older children, usually 4 to 6 weeks, those casts are on. But as we get older, adolescents, adults, you're going to see a longer time that's needed to heal bones. So you've got a kid in who fell down off the monkey bars and their wrist is swollen and painful and can't move it that well. So what do? Well, you take a history. Try to get a history from the child separately from the parents. Again, you are just being sure because nursing's job is to protect that child, okay? Because nobody else will. If a child is not able to walk on a limb, you can probably say it's broken. Even sprains and strains, they'll tap their foot down, okay, even though it hurts, but they will not if it's fractured. Goal, when we are done with doing what we need to do, casting, pinning, surgery, whatever, is that we want to reduce it and immobilize it so that we keep the function and we prevent it from being deformed. Now, put a cast on a child. And it's not just put a cast on and leave it. You need to be able to assess it. Now, that's a crazy picture, the top right picture, but that can happen if you left the cast on that was swollen, compartmental syndrome, and now you've got a necrotic arm, leg, finger, whatever. It can happen. So how do we prevent that from happening? Is that we teach. If we're seeing the 6Ps, 6Ps, so important. If you have a child with a cast on, these are things you need to teach them to look out for. Pain is getting worse, that the color is turning pale, but showing decreased circulation. Pulselessness, no circulation. Paresthesia is getting numb, circulation. Paralysis, can't move. It's swelling so much, the pressure in there so hard. This is something that's an emergent. They have to get to somewhere where they can loosen that calf, take it off, put a new one on, or whatever. They put a window in it, whatever it is. They've got to get that done. So children, the thing about adults, you get a white cast, whatever you want, right? It's a white cast. When you get into the pediatric population, you can have colored casts. Now, at the hospital I worked at, it's a strictly pediatric facility, trauma center. These casts are many different colors. We've got these pediatric ortho technicians that specialize in children and placing casts on them. And they have green, 2 types of pink, 2 types of blue. They have red, they have black, they have rainbow, they have army. They've got so many colors. And now we've taken that stress of getting a cast to, hey, what color is your favorite sports team to a guy, right? Or putting on the cast on a doll that a girl has. Again, distraction. They're not going to feel as bad getting a cast on. Now, when you get that child and they have their cast on, you need to teach them how to take care of their cast. The big thing is don't get it wet. We send them home with a plastic bag for arms or legs or whatever so that they can shower and keep clean, but to keep those casts dry. Remember, nothing inside that cast, no powders, no lotions, no hangers, pencils. You can't itch like that. What they say is a cool hair dryer, blowing hot, that cool in there. It helps because casts get heated at first. So you feel that heat, even with ice on the outside. So cool air in it. Children tell me that it really helps. Now, that's a cast. Now, here we go for a fracture that's going to have traction. We've got skin traction and we have skeletal traction, okay? what does traction do? What it does, it helps the bones align and has it sit there. I think the one that you could, I really explains it, is a fractured femur. A fractured femur is the long bone in your upper leg, and you've got these big, strong quadricep muscles. And when that bone breaks, those two pointed ends poke and the muscle spasms into the muscles, okay? And it hurts. So even down in the emergency room, we have a fractured femur. Immediately, we get him in traction to pull that femur and make the bones align to prevent muscle spasms, to prevent pain, okay? So that's skin traction. That bottom picture is Buck's traction. Look at it. That foot is not at the end of the bed, and there's this string that goes over a pulley that there's a weight hanging there. The weight depends on the size of the child, but that weight keeps that femur together. Never, ever take it off, okay? What is your job if you have a patient in traction? Well, you got to make sure that the foot's not touching the end of the bed, so there's good pull. Neurovascular signs, of course, that's always a given. But document that the weights are hanging freely. How much are those weights on there, okay? And of course, those neurovascular signs. So traction, whether it is one of these tongs into the head or one of these big devices, that's usually used when they do surgery on the top two vertebrae, and you'll see them on there to hold the neck straight until, it gets some good healing. And nursing care is just pin care at this point on these things. But traction is to relieve the fatigue, is to put those bones together to immobilize it, because that's going to help it heal quicker. And of course, you don't want any of those muscle spasms going into that nice sharp bone, creating pain. So Buck's traction, there's a nice picture. And right below it is one similar. It just has an extra piece there, Russell's traction. And both of them are used for fractured femurs. You've seen those for fractured hips in adults, I'm sure, but that's what we use for fractured femurs. The one on the bottom right is something called Bryant's traction. This is used for hip dysplasia. I'm going to go into other things that are, but this one here, Bryant's traction, is used for the hips on children that are less than 30 pounds. The Pavlik harness is usually used up till about 6 months. And if that doesn't work, they can either put a spica cast or they can put them in Bryant's traction. Okay? This is what you need to know. The child has to be less than 30 pounds. That is a right angle that they're sitting at, and the buttocks is slightly off the ground, and it pulls the hips up into where they need to be. Now, other things that we can use for fractures, whether it is a shattered bone or I've seen them break bones in order for you have a short leg, you can make that leg longer by using these external fixation devices. Again, this is all about pin care. That's all we do for it. Pin care, checking neurovascular signs. Now, amputation, yes, children do sometimes need amputations, and sometimes they're born without limbs. And the care for an adult or a child is the same. Of course, checking the stump, preventing infections, and keeping that area clean for a prosthesis. Phantom pain will be in a child just like adults. It's the same thing. I met a little girl through a friend of mine who came to my house. I think she was 5 at the time. My kids were maybe 9 and 11, I think they were. And this little girl came into my house, took off her legs to shock my kids, and then was chasing them up and down the stairs with her prosthesis. And she acted like she had no disability at all. I mean, they were born with it. It was refreshing to see her so involved. And she didn't care if she didn't have a piece of leg. She's going to beat you up with the other side of it. We know sports, kids, oh, they love competition, don't they? So remember, in sports, there's going to be injuries. Always remember, hydrate, hydrate, hydrate. Remember, we don't want to dehydrate any kid, acute renal failure. Also, we need to make sure that we have the proper equipment on these children. Again, if they have other special needs, diabetic, make sure they eat before. If they're asthmatic, make sure they have their inhalers. I mean, all of that stuff goes involved. But again, it's all about protecting the child, keeping them safe, and from, away from injury if we can. Overuse syndrome is another one of those things that we see. We see that children today are working harder and training longer. It could be because they want a college, scholarship. So they do things over and over and repetitive things, and it can cause what we call overuse. And it does swell and it does hurt. All right, so we've mentioned a little bit about developmental dysplasia of the hip or congenital hip dysplasia. Girls are more than boys, believe it or not, in this one. What would we see? Now, what does a doctor do, the pediatrician, when they come in to see your newborn baby after they're born? They have them on their back, they take their knees, they bend them up, pull them out, and they open their legs back and forth. What they're looking for is hip dysplasia. If there was a hip dysplasia, one hip was out of joint, and it could be a little bit or a lot. It could be just a little bit out of joint, or it could be quite out of joint. What are you going to see? Well, if my hip was up here, my leg is going to be short. If you looked at their gluteal folds, they're going to be crooked, right? And as you're putting their legs up and down, you're going to see clicking coming in and out of those joints. So positive Ortolani, positive Barlow test, okay? Those are things that you would see. So treatment. Remember, this is a congenital. Newborns are born with their hips not in place. Remember, they heal in 3 weeks. So early intervention is what we need. And what we do, that picture down there, we take a baby, we put on a cotton t-shirt, put the Pavlik harness over it so that we prevent some of the rubbing, and that must be in abduction. The legs are putting abduction of the hip to get it to go back into place. That must be on 23 hours a day. 1 hour off just for you to take a bath and to inspect underneath and rub the areas, and after the bath and getting them ready to put on another t-shirt and put the Pavlik harness back on. If that doesn't work, they can go into a spica cast, or they can go into Bryan's traction. That might help. But we see that there are some difficult ones, some that wasn't seen right away. We didn't realize what it was. And these kids might need surgery. They have to cut tendons and bones in order to make it work. But hopefully we don't get to that point. Now, club feet. I've mentioned it. I've got a picture here and I've got a picture in the Kahoots that are going to show you. You don't have to know all these names. Club feet is when the ankles and the feet are crooked in some manner, severe or not as severe, okay? How do we treat club feet? Well, it's actually a very easy thing. What we do is we do casting. So we put a cast as soon as we figure it out onto those legs. And because we heal so quickly, that cast is changed weekly. You don't want it to go more than that. You want to get it up to where it needs to go. Like, look at this little picture here. 1, 2, 3, 4, 5, 6. This child had a cast on for 6 weeks to get their feet to where they needed to be. Remember, once they start to walk, they still need to be followed up with orthopedics or podiatrists because we want to make sure that the feet and the ankles stay where they need to be. But it's important, change the cast every week and getting it on as soon as we can. Now, osteogenesis imperfecta. This is one of those conditions that this child's going to be immobilized. Many of these kids never get up and walk. because their bones are so brittle. They've got broken legs and arms and whatnot before they're even 1 year old, just by gentle touching. Now, I've seen one, and that little boy stayed with us for about 8 months. And I was afraid to even touch the kid to pick it up. We used to pick it up with baby blankets to change the beds and whatnot. And even changing the diaper, you've got to be so, so careful. The thing with osteogenesis imperfecta, you have it, it's it, you're not curing it. You just support it with giving maybe some biphosphonate, maybe calcium, some diet, whatever, but doesn't really change anything. The thing we've got to be careful with is that we need to keep this child mobile. They're alert. They know what's going on, and their body's just breaking. They're always in pain, okay? Because there's always some sort of fracture, something going on. But we want to keep them at least to be able to be in a wheelchair to keep themselves mobile, because they need to take care of themselves in some way. At least they can move themselves around. They used to come into the cafeteria, and you used to hear them coming on their electric wheelchairs, and they'd have little horns on them going beep, 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 like, oh, here they come. And many of them were children with osteogenesis imperfecta. Now, leg calf birth. This is not an infection. This is an aseptic, means no infection, necrosis. That means the femoral head is dying for whatever reason. We don't really know. We don't know what happens, why it happens. We know it is boys more than girls, but sometimes it's one hip, sometimes it's two hip. But our concern is that femoral head. We need to get blood supply there as quick as we can. Usually, we see these children, and the way that we diagnose them is these kids all of a sudden are limping. They are stiff, sore, complaining of, they can't move their legs, the range of motion, all of this is being decreased. And this kid doesn't go out and play. There's no injury, nothing's ever gone on. So what's going on here? So what they do is they hear this history of this. In the morning they hurt, when they're sitting too long they hurt, and they tell them it's here, it's in the hip area. We'll do an x-ray, and usually you'll see like a fuzzy top of the head, which is showing you that there is something going on there, an inflammation of some sort. So how do we care for this? Well, we want to keep that head good, right? So what we have to do is bed rest, no weight bearing, and they take for pain and for inflammation NSAIDs, and that helps. Sometimes they put them on box traction at home, holding that hip straight, preventing movement, preventing it from any more necrosis occurring. And of course, remember, always bones, remember healing, remember diet, and remember protein. Now, there's 3 different types of spine problems. One is the thoracic spine, and they're like humped over. I call them a humpback. Makes different, you can see it. Usually older people, you see them, bent over, as I call it, humpback. This is one where the lumbar spine curves in, so you sort of stand backwards. This one's important to remember because there's a condition in muscular dystrophy that one of the symptoms is lordosis. So this is just an inward hump, and it's usually has to do with obese children can have it, and of course this muscular dystrophy that we'll talk about. The third condition, and this is the one that's mostly tested on, is scoliosis. Now, scoliosis is the S-shaped curvature of a spine. Now, the problem and why we should fix it, not just because you're crooked, but you are impinging your spine into the area where your lung should be expanding. If it's greater than 45%, they have to do surgery and they have to straighten it up. If it's less than that, we can do some different things. So, how do we see that they're having scoliosis? Many times we see this be very evident at that pre-adolescent growth spurt. So here we are with young adolescents with a crooked body and self-esteem and body image. Erickson, right? So again, this child needs some really good support emotionally. So treatment, t-shirt, cotton t-shirt. We put a brace over it. And again, 23 hours a day they have to wear it. They take it off 1 hour just so they can shower and put on a different t-shirt, okay? Now, they also will be in a really aggressive physical therapy program in order to strengthen their core muscles and their back muscles, okay? So we can keep them straight. Now, this slide says greater than 40%, make it 45. When it's greater than 45%, we will put in what we call Harrington rods. And if you can imagine a spinal column with 2 rods going on the whole spine, and they're attached to the little sides of the spinal column. This is a child, a patient that's going to have log rolling. You've got to keep that back straight. That's a Harrington rod. Now, we've mentioned osteomyelitis and the possibilities and prevention, etc. But let's say, okay, they do have osteomyelitis. I think probably one of the most times I've seen it is on their feet. Their toe gets a puncture and you get a osteo in the toe. Children walk around with no shoes all the time. They run out the door and they've got these feet that don't feel pain, I think, sometimes. My 9-year-old grandson never wears shoes. And I'm like, and there's hot cement. I live in South Florida. It burned. You don't feel it. But this is the reason why many of these children puncture their foot. Then, they don't pay attention to it. And then all of a sudden it hurts. And then, of course, then they do something, put a Band-Aid, but then it's traveling. Now the foot's getting red. Now we're saying, oh, I don't feel good. Now I'm starting a fever. Now we're going to see that systemic type of thing going on. So they go to the doctor. We do a CBC. We're going to show marked leukocytosis, which is elevated white blood cell count, which is showing you that there's a bacterial infection going on somewhere in the body. And you could tell because that foot's red. It's that. We're going to do an x-ray just to see if the bone has been already attacked. You'll see fuzzy on the bone, okay? And we might even do a bone scan looking at it. So you've got this child, you're diagnosed, you have acute osteomyelitis. The infection bacteria that they treat is staph. When we treat staph, we're going to be giving them IV aminoglycosides. Do you remember aminoglycosides from pharmacology? Vancomycin, gentamicin, all the CIN drugs. Well, that's the one that you have to do really careful blood level monitoring, peaks and troughs, right? Why? Well, these SIN drugs, these aminoglycosides, if they have too much, they can cause ototoxicity, hearing loss, and they could cause nephrotoxicity, kidney damage. So we have to watch them closely. So you really need close monitoring. Another thing with the osteomyelitis, they put them on bed rest. They most likely will have a PICC line put in, which is a peripherally inserted central catheter, so that they can just, hang the antibiotic whenever they're supposed to, have the nurse go to the house. Remember, it's not just putting them on bed rest, letting them rest, giving them antibiotics. Nutrition, nutrition, nutrition. Again, high proteins for these children. And remember that these kids now are home. They feel separated. Again, psychological needs for this one. Keep them happy. That would have to be you tell the parents. Now, I'll just quickly mention Ewing sarcoma. It's a bone cancer. It could be in a jaw, it could be in a scapula, a rib, it could be anywhere. So it's a cancer. we treat it like we treat cancers, radiation, chemo, and if we can, surgical resection. Most of the time, these have already metastasized. So if it hasn't, you can be cured. If it has, not really. So now let's look at juvenile idiopathic arthritis. This is juvenile rheumatoid arthritis. I mean, y'all don't know, but I do have rheumatoid arthritis. So I understand the whole plight of it. I understand being diagnosed with it or being not diagnosed for about 8 years. So it's one of those difficult things. Usually we see these children, toddlers, at ages 1 to 3. And what we start to see is when they wake up from naps and, bedtime, morning, they'll be stiff. And if they're walking, now they're having more trouble with walking and maybe limping. You might or might not see some joint swelling and disfigurement. And the one thing students forget as part of a symptom is these big red eyes. That's why I made it a big picture. They get this uveitis. Therefore, these children with JIA, because there's no cure, they must be seen by an ophthalmologist at least annually. How do you diagnose it? As I said, it took 8 years for me. I was telling them for 6 of them what I had, but nobody believed me. So, no definitive diagnostic test. But what can we test? Well, this is the body attacking joints, so there's inflammation. So let's look at all those inflammatory factors, the SED rate, the C-reactive protein. Then we could go in and look at the RA factor and the ANA. The thing with ANA and rheumatoid factor, sometimes it's positive, sometimes it's negative. It happened to me all the time. It's positive, it's negative, it's positive, it's negative. The body doesn't know what to do. Depends on, where you are in the cycle of that stress, etc. You might see that leukocytosis or elevated white blood cells with it. Again, part of that inflammation. So when I finally was diagnosed, and you don't need to know the name of this, but in case anybody comes across it, there was one test they just had come out with, and I don't know the exact name, but it was called a CCCP. And the level was up to 50 is normal. When it came back, and it was a send out to California or some crazy thing, my level was greater than 250. And they finally said, oh yeah, you've got it. So now let's start treatment. So what is the treatment for rheumatoid arthritis, JIA? Well, initially, because of the pain and whatnot and stiffness, they start corticosteroids, but that should not be long term. They will add on methotrexate, and then they will add on some sort of biologic like Humira, something to tell the body, stop attacking my joints. The other thing that's really, really important, because we want to preserve the function. We don't want those deformities and we don't want the pain because it hurts. Physical therapy, keeping moving, keeping the stress down as you can, right? Also, when those joints hurt, we can do either heat, don't put heat on me, or cold. Most patients like heat. It makes me feel worse. I want an ice bath. I will bathe in ice bath because it does help. So again, ask, do you like cold or do you like heat? Another thing, swimming as part of the physical therapy, you're buoyant. I'll go out in a pool for 8 hours and be very happy. Now, lupus is the other thing that the body is attacking your organs, your skin, your brain, your heart, your lungs, your liver, your kidneys, everything, okay? This usually comes out about 10 years late, late childhood to adolescence. It's probably from puberty and hormone. Some sort of, it could be infections or stress. Yes, it could, but also overexposure to sunlight. So what do you see? So this is a picture of that butterfly rash, because remember, skin is an organ. Might look like that, might be smaller than that, might be darker than that. It's just a rash on the face. It's called a butterfly, okay? You also might see things like nausea, vomiting, it's affecting the stomach, diarrhea, oh, the GI tract. It's also checking the joints, and it could cause stiffness there too. It also, the brain, it could affect. So forgetfulness, seizures, paralysis, pleurisy, it's affecting the lungs, pericarditis, affecting the heart. Again, lupus attacks everything. So our goal again is to prevent that body from attacking itself, to minimize the exacerbations, and again, have these kids live as normal as we possibly can, right? So, question. Kristen is 10 years old, sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider what? What's the epiphyseal plate?
The growth plate.
It is a growth plate. So again, you're worried about growth. Yes. So let's go ahead and do our first Kahoot. I'm coming. Can you see that? Thank you. Now remember, the one thing about Kahoots, we don't go back and look at results and who answered and who did what. This is something that I personally have made for you all to test your knowledge on what I just told you. What are those concepts I really need to understand? Okay. And as you're doing these Kahoots, write down, oh, I didn't get this. So you can listen to the recording again, or maybe look it up in the book. Okay. That's what this is for. I've spent, I can't even tell you how much time doing these things, but they help you. So I keep doing them. Who wants to win? I think Jennifer wants to win tonight. Let's get going. Well, let's get her skeletal. Multi. What is a priority for a nurse to assess following a cast application? What's the acronym I told you? There's 6 P's, right? That's what you always check. Pulses, pain, movement, paralysis, sensation, paresthesia. P, 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 P. That's what you test. You check for. Making sure blood's going where it needs to go. Multi. Patient teaching for a child with a fractured bone that has had a new cast applied. So remember cast, that cool air on a hair dryer, it works. No lotions, no powders, nothing to stick in there. And we have to keep the cast dry. No swimming. it's going to put it moist inside, and that's actually very dangerous. It's going to grow mold and whatnot. So no swimming. And when you shower, put a bag on. What should the nurse monitor after a soft tissue injury? What did I say will always be the answer? Soft tissue injury. You're always going to check neurovascular signs. Neurovascular signs. You want to make sure blood is going down there. That's our biggest concern. A fracture that penetrates the skin is called. So if it's fractured and it's coming out the skin, it's an open or compound. I never mentioned green stick, so that couldn't be an answer. Okay? Don't pick an answer that you haven't heard me say the word. Multi. Bryant's traction. So remember, Bryant's traction is used for hip dysplasia. It's for children. It has to be less than 30 pounds. And you're at a right angle, but the butt has to be a little bit off the ground. And that's how it is done. What is the priority nursing care of a child with a compound or an open fracture? Priority. What is our concern with an open fracture? Our biggest concern with an open fracture is the possibility of osteomyelitis. Your priority is IV antibiotics. Okay, nursing care. What is priority nursing care for a child who fell off a second floor balcony? I've actually seen three. One did okay, one did so-so, and one didn't do well at all. They went up on the tables and the chairs, young kids, and looked down over the little railing and fell off. So our big thing is when you get these children into the ER, they're going to be immobilized on neck collars, and some of them, they even tape them to the backboards. You have to maintain that child's spine as still as you possibly can. You can cause paralysis. Principles of managing soft tissue injury include, I've got a sprain. What am I going to do? So again, it's RICE. It's the acronym. We're going to rest it, ice it, compress it, and elevate it. Epiphyseal plate fractures in children may. What's an epiphyseal plate? It's another name for, it's a growth plate. So again, it's all about disrupting the growth, crooked bones, shorter legs. We don't want that if we possibly can. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? So if there's an impairment, there's pallor, there's pain, there's paresthesia, all of that. Now there's a no pulse, you're in trouble. That's an emergency. Call the doctor immediately. We need to get that blood supply. Multi. How should the nurse care for the skeletal traction for a child with a fractured femur? So when you have a child and fractured femur, they're in Buck's traction, make sure that we document that the weight that's hanging there, what's the weight? Make sure that it is free moving, right? Very important. Never, ever take it off. And no, you would never reduce it. When caring for a 9-year-old in Buck's traction, what action by the nurse is correct? So again, Buck's traction, you're going to do capillary refill on them at least every 4 hours or more if you need to. And again, you'll never, ever, ever do anything to get those weights off the child. You take the weights off, that bone disconnects, and now that child's in severe pain and muscle spasms. Don't want that. What position do you put the legs of an infant with hip dysplasia? So when you have a child with hip dysplasia, you put them in abduction. You have them so they're like a frog, okay? It's called abduction. What statement by parents indicating more teaching is needed regarding their 2-month-old infant with club foot or feet? Which one here is wrong? So remember, with club feet, you have to do as quickly as you possible, get it on. Know that every week you have to change that cast because they heal bones in 3 weeks as a neonate. And again, as they get older, they're going to have follow up with, the orthopedist or podiatrist because they want to keep their feet straight. A multi, osteogenesis imperfecta. I've actually seen documentaries on parents being accused of being abusive, and the child had osteogenesis imperfecta. So that's something that can happen. But what this is a condition, brittle bones, and everything is crooked, and there's nothing you can do about it. It's all supportive. What is the pathologic cause of leg calf birth disease? So, leg calf birth is what we call an ischemic aseptic necrosis of a femoral head. That means blood's not going there, but there's no infection, and it's damaging or killing that femoral head. Kyphosis.
Miss Bogart, can you check your message?
Right now. Kyphosis is the thoracic spine, and it causes what we call a humpback. Multi. What assessment indicates an infant has developmental dysplasia of the hip? So again, remember when we're talking about developmental dysplasia of the hip, it's somewhere that leg is going to be shorter. We're going to see different leg folds, and it's parts of Barlow and Ortolani. Okay, a moral reflex is startle. It's when you make noise or you bump into a crib and their hands and feet go up. And Babinski is on adults. For children, it's bottom of the foot, has nothing to do with dysplasia. Lordosis is described as. Okay, lordosis, inward curvature of the lumbar spine. And remember, that's with Duchenne, you see it. Scoliosis is those S-shaped curvature of the spine. And we usually see that pre-adolescent growth spurt. Adolescents with scoliosis that have up to a 45% curvature of the spine would need to do what? What's the treatment? Do we have to do surgery, or is it just going to be putting a brace on? What's that number mean? Up to 45. So when we have up to that 45-degree curvature, it's going to be putting on a brace and wearing it 23 hours a day with a white cotton t-shirt and physical therapy to strengthen the muscles. Over that, it's going to be surgery. So over 45%, they would have to have the rods put in. Teaching for child with scoliosis with less than a 40-degree curvature. So if you're less than 40 degrees, you're able to wear that brace 23 hours a day, 1 hour off the shower, white cotton t-shirt, no lotions or no powders. I mean, rub the skin, yes, but you're not going to be slathered in that. No. And of course, it's physical therapy. Multi. A Pavlik harness. What's that? So a Pavlik harness is used on children born with congenital hip defects, and they're somewhere, right? We got to put it back into place. This harness holds it into place into abduction. Remember to check underneath the brace, rub it, of course, and of course, have it off for the bath. What is osteomyelitis? Well, we've talked about it. We know how to treat it. We know symptoms of it, but what is it? So again, it's an inflammation of the bone caused by an infection. Just break down the name, osteo, bone, itis, infection. Goals for JIA includes. So, it's just to reduce the joints and so that they don't hurt in the inflammation, JIA. What priority action should a nurse take to a patient with suspected spinal cord injury? What's your priority? So again, spinal cord injury, you don't want paralysis on them. So immobilization, keep that spine really straight because you could paralyze them. Last one. Most common causes of spinal cord injuries are in children, or actually anybody, right? And we know that's motor vehicles, sports, everything. Savannah, good job. Number two. Mel, number one. Hey, and we got Shanna and H. Okay, let's go ahead. Let's finish up with the other part. Okay, great. Can you all see this? All right, let's go into neuromuscular muscular dysfunction. So when we think of neuromuscular, one of the diagnoses we think of is cerebral palsy. We know that this is something that has to do with muscle tone, coordination, and postures. So what causes cerebral palsy? Why doesn't the muscles work the way they should in cognition? Well, it could be because of the brain, the way it was formed. It's not right. Some sort of an occlusion. It could be prematurity. One of the biggest things that I've seen is when child's had a hypoxic or an anoxic episode and they don't get the proper oxygen and then cerebral palsy. And it could be mild to severe. So diagnosing these children as quick as we can, of course, is the most important thing. Early intervention in these children is that. Now, spastic cerebral palsy is one of the more severes, and it's when the basic word is hypertonicity. It's like they tense up and they have really poor posture and they can't maintain balance. These children need to, wheelchairs, and they need, harnesses and making sure that they're not arching out of the chairs and whatnot. Now, what do we see and what's our concern? Well, cerebral palsy, these children are going to have some delayed motor development, of course, delayed fine motor. And of course, they have these really abnormal motor types, the way that they move things and the way that they posture. Again, safety is huge with these children because of this. So as our goal with children with cerebral palsy, again, you're mild to severe, but even the most severe and spastic cerebral palsy, they've got some really good understanding of surroundings. So let's give them some way to get around, locomotion. The other thing is communication. Now, I used to work with clinicals with a little boy named Jonathan, and he was a nonverbal spastic cerebral palsy child. And he would see me and just his face would light up and he would just, waiting for me to come hug him. But he had this little pad where he could actually say words to us and tell us what he wanted to say. March of Dimes would give it to him. So communication, very important. And this was a child years ago. We wouldn't think that they had that ability. Again, with cerebral palsy, education, knowing that even the most severe, like Jonathan, I was watching him learn colors and numbers and shapes, and of course, being involved with other children. A lot of the therapy is that posturing and that muscle. So it's ankle brace things, orthopedic surgery. Sometimes they're so spastic, getting them into positions that they can be functional. Stuff for pain. Jonathan was on a Parkinson disease medication, carbidopa, levodopa, that helps with the spasms, botulism if they're really spasm. And remember, most of these have epilepsy, the more severe cerebral palsy. So they're on medications for the epilepsy, which causes like gingival hyperplasia. So be careful with their teeth, and of course, teach those parents it. And of course, that interventions, physical, occupational, speech, whatever they need. Now, prognosis is again mild to moderate. It depends on how severely they do have cerebral palsy. Now, the moderate ones usually can get up and walk around in some manner. Sometimes they need a walker, and that just helps them. Some canes, some just walk with a limp. It all depends on the child. So, as a nurse, our care, making sure that the parents at home have what they need or directing them where to go, teaching medication administration. Always number one on cognitively delayed children, safety, safety. Always be aware of that. Keeping their minds active, and of course, therapy, physical, speech, occupational therapy. And again, that whole family needs some help. So where do they get that? Now, types of neural tube deficits. Do you remember in pharmacology when they asked you and told you that folic acid's needed or you could have neural tube deficits? Well, this is your neural tube. And I was like, oh, this is interesting. Now I can show it because I taught pharm for a while. But anyway, that big purple bulbous thing on the back of that infant is the spinal column and meninges. It rips the nerves from the lower extremities and the spinal column, and it rips out into that bulb there. So you've got decreased sensation in lower extremities. Those are called myelomeningocele or meningocele. The other ones are slightly different, but we're going to describe those. So again, what causes these things? Well, folic acid, you'll see it in the next slide too, but it could be the mom. They were obese, diabetes, or maybe low B12. And again, how do we take care of these kids? Well, again, this big purple bulbous thing is ripped up from the lower extremities, nerves and spinal column and meninges, and it's open to the air. So place a sterile dressing on it with normal saline, and it's a dressing over it. Please keep that skin, the skin integrity underneath, because we're going to have to close it, and we need to have good skin to do that too. Because of the ripping of the nerves, you got to be careful with urine. You have to be really careful with the bowel also. Now, years ago, we had a big concern with latex because you really didn't have many other gloves than that. Today, we rarely use it, but we'll always put them down, latex allergy, because they are manipulated a lot. Again, how do you prevent neurotubes? There you go, folic acid. Now, here's some muscular dystrophies. I'm going to mention two. This one is Werdnig-Hoffmann, and it's also called a floppy infant syndrome. This is again muscle wasting and wasting of skeletal muscles. These children have very poor tone. They're not going to lift their heads, they're floppy, and they sort of lay in this frog-like position. Their cry is bad, no muscles, etc. And it progresses. And by the age of 2, they usually die. So that's a really sad one. Now, Duchenne muscular dystrophy is the one that is tested on. This is the muscular dystrophy that they describe muscular dystrophies with. Now, this is one that is boys, and it comes from mommy, a recessive X-link that gives this disease to this boy. These boys are usually diagnosed between the ages of 3 to 7. So you're going to say what happened before that. Well, these children are cognitively delayed. Sometimes they're a little heavier, and they do have growth where they get up and they'll start walking and doing okay. And then all of a sudden, about age 3, you start seeing them falling. They are weaker. They just look differently. And there again, this is a 3-year-old boy that we're looking at. Sometimes we're going to see the calf muscles are hypertrophic. So big calf muscles, like, so they're working like really hard. The problem with muscular dystrophy is a progressive muscle weakness. And what has muscles? The lungs, the diaphragm, and the heart. So usually they die in teenage from cardiac or respiratory failure. So you get this boy, age 3, who starts to waddle and starts to fall. He starts to now, you know what a Gower sign is? When you get on the floor and you walk up your legs to sit up like I do every time I'm on the floor, like an old lady. That's what a Gower sign is. This is lordosis, like I described before. So they got that inward curvature. And then, of course, you might see the hypertrophic arms even, or the calves there. As I said, you're going to have a little bit of cognitive delay there, some from mild to moderate, and the child will be overweight because they don't use their muscles well. They don't burn the calories. So there really is not treatment because there's no cure for it. All it is keeping the muscles toned the best we possibly can for as long as we possibly can. Basically, that's it. And if this parent wants to have another child, genetic counseling is absolute must. Now, Guillain-Barré syndrome, it is an infectious polyneuritis. It's not an infection. It's not from a bacteria. It's something that I've seen that can occur after a upper respiratory in the last month or so. They're saying children ages 4 to 10. So what do you see with this child? So all of a sudden, you start to see the feet getting a little numb, and you start seeing them stumbling or complaining they don't feel their toes or whatever. And then it goes, and ascends upward, that word ascends upwards, and now it's going to hit my urine, my bladder, my bowels. Now I can't urinate. I can't move my bowels. And then it keeps going up, ascending, and it hits my phrenic nerve. Now I can't breathe. So what do you think your responsibility is? Respiratory, monitoring the breathing on that patient once we've determined it is Guillain-Barré. Know that with all this numbing that's going on, that urine and constipation is usually the one that brings them in. They're this numbing, they say, oh, must be my back, must be this, that. But anyway, so how do we take care of this? Well, it's basically symptomatic. It will go up to the point, it'll hit the diaphragm, they'll end up intubated for whatever period of time. Could be short to long. There's no rhyme or reason. You really don't know. As this child starts to now go descending the symptoms, because that's what happens, it goes back down the way it came back up, all of a sudden you start to see them breathe. And that's when you know you're on your way back. The treatment of this one is, of course, a ventilator, on it, taking care of those lungs, steroids maybe, and IVIG, boosting that immune system. And plasmapheresis also cleans up the blood also. And then again, we're going to see all of a sudden it goes to the bottom, and they're probably going to need therapy because they're going to be weak after that. Now, tetanus. I stepped on a rusty nail, right? Well, what happens with tetanus is they get this tetanus germ into them, and it attacks the neck and these muscles up here, and it squeezes it tight. And they go into like a laryngospasm, and then it goes into the arms, and it's like being spastic times 10. Okay, stiff, tight, painful muscle cramping. So these children are the sickest. If they last for 4 days, they probably are going to recover. Most don't. That's how bad it is. So what do we do for this child? Well, we know that it's all respiratory that's starting and the anxious and whatnot. They're going to be intubated. They're going to be paralyzed and they're going to be sedated. We're also going to be taking care of that wound. It's part of the treatment. Don't forget tetanus. That was a point of entry. So we're going to do that. We're going to give those tetanus toxoid and immunization. So in the ICU, respiratory support, they, again, tetanus toxoid and wound care. And we're going to paralyze these children and sedate them because they are so painful, this muscles, that we're going to make them not feel that they're moving and then sedate them because they're wide awake. These children are sick. So how often do you take a tetanus shot today? It's every 10 years. It used to be every 2, then it went to 5. And tetanus is also now given with diphtheria at the same time, is what I've been seeing. Okay, botulism. Botulism, I've seen when I came to Florida and had a culture shock and found out that the Hispanic population, grandmas, like to give honey or carrot syrup to a baby who's constipated. They felt that it helps them move their bowels. This is something I found. Well, it can cause botulism. Botulism is very similar to tetanus. You sort of see that starts with that in the face and then the vomiting and then it's a paralysis. Okay. Same type thing. So, how do we treat this one? Just like the other one, we're going to give IVIG and, of course, respiratory. Always don't ever forget with any children critically ill, one of the priorities will always be nutrition. Now, spinal cord injuries. Spinal cord injuries can be from anything. It can be motor vehicles, sports, pulling on a baby's head, the neck, and birth could happen. Or you go forward and your head goes back and forth. That can also cause a spinal cord injury. So again, what do? Absolutely keep that immunization. Don't move it until we get a clearance, x-rays, et cetera, for it. Because we can have a child that's partially paralyzed in the lower legs, and you move that neck wrong, and now they could be paralyzed for life. So again, immobilization. So a progressive infantile spinal muscular atrophy and the most common paralytic form of the floppy infant syndrome is which one? It's actually C. I don't want to cause you pain. All right, let's go ahead and do our last cahoots. It is shorter than the last one. You all see my voice is going. And that, my friend, is rheumatoid arthritis. There are joints around your vocal cords. Very unusual, but it happens to me. All right, let's get going. Ahoot. Neuromuscular dysfunction. Goals for JIA include we did that before, didn't we? What might you anticipate for a child diagnosed with JIA? What symptoms? What are you worried about? So facial rash is lupus. It is not rheumatoid arthritis, okay? You're worried about joints, walking, and uveitis. Remember that, right? Those big red eyeballs. What is cerebral palsy? Well, cerebral palsy is all about the muscles and the body movements and the coordination. Okay. What are the signs and symptoms of spastic cerebral palsy? My little Jonathan. You know, there's some children with CP that can walk, just a limp, and there's some that will always be in a wheelchair. They'll never walk, even in a walker. And it's all of these things: poor posture, poor fine motor, poor gross motor, hypertonicity. That's that spasming. That differentiates that from other types of milder CP. And of course, poor balance, because they have no muscle control. A multi. When feeding a child with cerebral palsy, what's important to remember? Remember, cerebral palsy is the inability to control your muscles. You need muscles to eat and chew and to swallow, right? So, knowing that, so again, children with any muscular dystrophies, anything with muscles, delays, etc., remember, keep that head of the bed way high, as high as you can, and give that child the chance to chew and swallow so that they have the time and not to aspirate. And you would actually thicken the liquids. You don't have to, because a child has cerebral palsy, even nonverbal. If they can eat, they can eat. They don't have to have a gastrostomy tube. A myelomeningocele. What is it? Myelomeningocele is a hernia, that back, that big purple blob, which is the spinal cord and meninges, and it pulls those nerves from the lower extremities up. What can help a child with lupus prevent exacerbations? What's one of the big things I told you about lupus? We know stress and hormonal balances, infections, and all those things can cause, but also being out in the sun too much too, right? That's one of the big things. One of the things with any type of immunosuppressed like this, or even JIA, prophylactic antibiotics and steroids before dental extractions are extremely important. Infants with myelomeningocele demonstrate again, we've pulled those nerves from the bottom, the lower extremities up. We've ripped them. They're going to have motor and sensory impairment. Some have minimal and some have complete no sensation. Myelomeningocele have decreased motor and sensations of the lower extremities. What should you monitor closely? What's the one thing you really closely monitor? You've got decreased sensation down below. And any of those could be an answer. But the big one is urinary retention. Think about the nerves from the lower spinal column. It goes into the bladder, it goes into the GI tract. Monitoring urine, because many of them end up being catheterizations every 4 hours for life. They don't have any feeling. And remember, monitoring their bowels and preventing constipation, etc. A key feature of Duchenne muscular dystrophy is muscular dystrophy. The muscular dystrophy of any type, whatever name, it's progressive muscle wasting. And again, the muscles that go, diaphragm and the heart, and that's the end. What is one of the procedures that a child with possible Duchenne's may need to diagnose this condition? You have a child that was up and is walking and now is waddling, falling down, and you want to see, do they have Duchenne muscular dystrophy? So remember, we're going to go in and check the muscles, seeing how they respond to a stimulus. And after this exam, remember, they have stimulated muscles like this child just ran a marathon. He's going to be stiff. It's going to hurt a little bit. So prepare the mother and the child so they can have some Tylenol or Motrin or whatever they need. How is Duchenne muscular dystrophy inherited? This one comes from mom. Okay, that's why you need genetics to see what's going on. If these parents want another child, they can make a decision. In caring for the patient with Guillain-Barré, the priority concern is have a child admitted, diagnosis, Guillain-Barré. What are you monitoring? Priority. And of course, it's that phrenic nerve. We don't want that to go out and stop breathing. Yes, it's all about the airway. For a patient suffering with Guillain-Barré, they would complain of weakness that was what? Remember, it starts from the feet and goes upwards, right? What is that called? It's called ascending. Worse on awakening is JIA and lupus and all those things. No, this is numbness. The nerves stop working and then it goes up from the feet upwards. Multi. Treatment for Guillain-Barré include so Guillain-Barré is not an infection. So antibiotics are not needed. We're going to give IVIG, plasmapheresis, maybe steroids, and we're going to take care of the lungs with a ventilator, respiratory support. Now, heparin may be used to prevent, things like DVT because of being bedridden and can't move, but it's not the treatment for Guillain-Barré. It's the IVIG and respiratory. Remember, it is not a bacterial infection. What type of cerebral palsy causes hypertonicity and poor fine motor skills? Like Jonathan. So this is called spastic hypertonicity. Hypertonicity, it's spastic. What priority action should a nurse take to a patient with a suspected spinal cord injury? Priority, spinal cord injury. And of course, that's keeping that spine immobilized. Don't want a paralyzed child because of you. You should get a tetanus shot every whatever years. How much? I remember it's now combined. I was like, oh, okay. And again, it's every 10 years. And last question, which is a symptom of tetanus? So tetanus again is that lockjaw, and it causes severe muscle cramping and spasming and just tensing of all the muscles. Again, we have to take care of the wound and give those IVIG with that. Number 3 is Savannah. Good job, Savannah. Number 2, Mel. Oh, good job, Mel. Number 1, A. Number 4, H and Atara. Good job, guys. All right. So that's about all I have with class today in case anybody wants anything. I'm done for the day. Um, I will be sending, in fact, I'll be posting the Cahoots. I'll be posting the recording. I'll be posting my PowerPoint to your announcement also, of course, along with my own class, so that you have that quick, probably within the next hour or so, you'll get it. Remember, next week is the exam. Try to get here as early as you can, a little bit earlier to get signed in. There's a couple reviews that are already out. Your professor did one today, so there's 3 that are out now. Professor Morris, me, and your professor, Professor Pace Chismar. So those are 3 great ones to listen to. So if you can get to another one, I've posted them on all of your calendars so that you could have them there to pick and choose as you like. You all have a great night. Thank you.
Thank you, Professor Bogart. Have a good night.
You
Thank
too.
you. Good night.
My pleasure.